This presentation involves a lot of emotions. Those emotions are related to our decisions of when and where. So, in the beginning, I will start with purely a family issue, which helps you to understand the importance of what I'm talking about. And then we relate those emotions to actually our decisions of when we should do what procedure surgically and so forth. This diagram to you is maybe it's a simple family photograph. Yeah? But I will tell you all the hormones that could be secreted in a human being is secreted by all of the people in this photograph. Now, you can tell me when dopamine is released. Happiness, how? Like when you're holding, sorry? Pleasure. So give me an example. Scrolling with your mobile, when you place the implant crown and the patient says, thank you, I've never had. Always I go to the other dentist and they grind and it's not fitting. You put it in, this is a miracle. Like those things will bring dopamine. What about serotonin? Serotonin is sorry? No, all of these are happiness hormones. We are trying to learn how to bring this to the patient. Okay? If you open your phone and you go to consensus, you have these four hormones. Can you read those four hormones? So why am I bringing this is, if you can include certain actions, certain sentences, certain behavior, certain procedures, that it brings these hormones to yourself.
You want him to read?
Either him or her. You are reading?
This photo, yeah?
Yes.
Okay.
Yeah, go ahead. Tell us, what about serotonin or dopamine?
Dopamine,
How does it release?
the reward chemical, create something, achieve a goal, complete a task, self-care activities.
Okay? So when you do something, you finish it to the end, whether the patient or the patient comes on appointment, and you say, today you came on the right time. That itself is an acknowledgement. Anything you do, which is completing a task, crown prep, crown cementation, implant placement, bone graft, whatever, same thing to the patient. When they do something so that starts the conversation with the happiness. The second one you have is
Oxytocin. The love hormone, socialize, hug a family member, friend or your pet, help others.
Okay, so even a handshake, even a tap on the shoulder, even a smile will excrete oxytocin. And this is necessary, even if you look in the eyes and you talk with a smile, and they will release that, and you will also, if they smile back to you, it's a double benefit. The patient is happier on the chair because there is some kind of a physical communication. Next.
Serotonin,
Yes.
the mood stabilizer.
Yes.
Get out in sunlight, try mindfulness, be with nature, try meditation.
Okay. So basically, if you talk a little bit of ethics to the patient, or the patient talks about their family problem or something, you listen and you have compassionate. Nature, if you have a nice color of a beautiful photo in your room, or you show a beautiful smile to the patient and you relate that to their life or their nature, yeah, that's enough. That makes them feel very comfortable. And yourself also, when you enter a room where it's beautiful, you feel nice. So basically, beauty will add that excretion of that hormone. And the last one,
Endorphins, the painkiller. Exercise, listen to music, watch a movie, have a laugh with friends.
okay. So normally when those big built-up patients come, I tell them you will not feel any pain. They say why? I say because you have endorphin in your body. You always exercise. So they enjoy that. They're appreciated by the. Actually, they get the benefit from the serotonin and the oxytocin, but they do also, most of them, have higher tolerance to pain. And people normally who exercise, frankly speaking, their success rate in implant is also higher. Because they're happy people, they take care of themselves, the body is, the blood flow is faster. So, yeah, so basically, this today's topic is for yourself and your patient. Try to always excrete all the four hormones of happiness. Find ways, so you don't target only dopamine alone. Many of you say, I know how to make the patient release dopamine when they come to me. Fine, but what if you can find a way to include all the four hormones for yourself, so you are happier with your patient and for your patient. Now, just to summarize this, the other thing here is the short time smiles, sometimes it's a fake smile where the reception gives all the patients, and there are the long ones which it's actually deep from inside. There is something that quickly you try to just give an improvement, or you do something that the patient will live with that crown for 10, 15 years. And this is directly proportional to you accepting the responsibility of, when you have all this happiness from inside, generally you go for long improvements. You want something perfect, nice, and you're ready to take the responsibility, bend your head, and so forth. Just to summarize this, why this is having all the four elements in them. On this day, this gentleman has come to get married to this lady. Alright? So at night, on this day, in this location, there'll be a wedding. Okay? And everybody here has come from different places. For example, this gentleman has come all the way from, this is in Sharjah. This is the owner of the house. He's wearing a tie, but he's wearing a sleeping pajama. He's come all the way from Abu Dhabi just to go, he wants to connect the wires for electricity. At that time, in Abu Dhabi, there was no electricity, or in Sharjah. So he's bringing a generator to have wedding. This lady has come all the way from Dubai to make the wedding dress. This lady doesn't know how to make the hair, for the wedding. This lady, which one is it? I'm looking for the one who's making the hair. This lady, she's come all the way to do the hair part for the wedding. This guy is the photographer for the wedding. And who else has come all the way? This guy has brought his wife from Dubai to take care of the dress. Somebody is in charge of hospitality. Somebody is in charge of the food. So they all gathered so the wedding will go well. Now take that concept. Everybody has come from all over to make this event successful, right? Take the same principles to implant dentistry. Yeah? You can bring all the elements. The lab is called, is it zirconia, is it metal? The scanner is there, all the company who sells you the implant, you plan the whole details to make sure this is successful result from all over, all the possible that you have. Okay? By the way, this is my dad and my mom. So, connecting when and where, long-term follow-up, long-term improvement in the results. I have found that there are these 10 steps, which is annually we are doing. Those are the only way we can make sure that this big thing, which is implant dentistry, the same way you do a lot of things in your marriage life to last for 10, 15, 20 years, same thing, you have certain steps to do so this implant will last longer. Okay, so what we have found is during these few years that without having a basic elements in terms of maintenance, there is a chance that the patient comes later and we examine the problem, but because we don't know where did the problem or when did the problem start, we will not know how to correct the problem. So this 10 steps actually somehow is like insurance for us and the patient, that whenever something wants to go wrong, we catch it in the beginning. The issue of peri-implantitis is now close to 69% and 60% at the subject at implant level respectively. So you are looking at something which is no longer 3%. When you join the program and you read in the statistics, you remember the 3% failure rate. That's why you joined the program and said, I have to learn implants because it's 97% success and 3% failure. But when you come to the real life, the failure rate is more than 50%. So if you have a practice that you could have close to 60% problems, then you must pay attention to this lecture. This is the only way that you can reduce this number. I'm not saying you can reduce it to 3%, but you definitely can reduce it much more than 40% failure rate. Now, we start from the beginning. Of course, you have to know which implant you are working with. We go to the first rule of the problem maker, where the bacteria comes and resides. You deal with gram-negative, gram-positive. You deal with oral flora, and you deal with respiratory flora. They are two different. Respiratory flora, when they are there in the mouth because of communication, you get to a more complicated scenario. Now, when you see the patient has 1+ calculus, it's very different when the patient comes to you with 3+ calculus. The entire bacteria that are living there, they are totally different. So, if the patient comes, this is done annually, by the way. These 10 steps are done once a year. So as soon as you see the patient is 1+, he remains as a once a year annual checkup. Once he's not 1+, he's 2 or 3, he's no longer an annual patient. He becomes either biannual or triannual. That means either he'll come every 6 months or he'll come every 3 months. So 1+ is once a year, 2+ twice a year, 3+, 3 times a year. It's exactly related to the plus where you see in the calculus in the mouth. Then you take the X-ray. The X-ray are periapical. CBCT is the last. Panoramic and CBCT. Whenever the patient comes, you need to know the vertical bone height and compare it next year with this year's vertical bone height. Yeah? So panoramic becomes a necessary every year, without a doubt. Now, already the ADA has removed this collar thing from the, it shows it has no effect on your, so if the patient insists on wearing something, you should convince the patient it doesn't make any difference. It's going to only ruin my image. So don't put anything. don't put it anymore. Go to ADA literature. It's been there since 3 years. Show the patient, American Dental Association, UAE, all of them, they are saying it doesn't make any difference because they think it does make a difference. So you take the first panoramic to see the vertical bone height, the horizontal bone loss compared to last year, and you note it. If there is a difference, then you either switch to periapical to know exactly how much, or you switch to CBCT to see the vertical and the horizontal at the same time. So if you do a bone graft, you have to have a CBCT because you don't know where that bone graft will go. And you have to repeat it every year. If you have a thick bone and your everything calculus is 0, you know the calculus classification, 0, 1 plus, 2 plus, and 3 plus. So if it's 0 and the vertical bone is good and there is no bleeding and so forth, then there was no bone graft, then you might not ask for a CBCT. Otherwise, CBCT becomes an annual thing. You might say, every year I have to take CBCT? Yes, but only on the area of the implant. You don't have to do a full mouth CBCT. So basically, the X-ray is important for you to see the progressive bone loss, vertically or horizontally. Now, why would I need that information? Once you lose the 2 millimeter of buccal bone, you call the periodontist and say, should we only do soft tissue grafting or only bone or combination? So it depends. Once it's 1 millimeter every year or 1.5, you can immediately do a simple procedure. But if you are not doing this every year, and the patient is coming just to clean every year, and then suddenly you see a big gap, and you didn't do your X-ray every year, then you might have to remove the implant. It's too late, or you have to shave the implant, or do something drastic. So that's why annual. Bleeding is the precursor for peri-implantitis. So if you have bleeding, it's within the gum, so it's called, thank you. So this is basically, it's only like a warning to you. If you place your probe only in the area, you don't have to push down. Once you touch the free gingiva or junctional epithelium with your probe, you don't have to go to the connective tissue. Just the first 2 millimeters. You remember there is junctional epithelium and there is connective tissue around 1.5, 1.5. You don't want to go to the more than 1.5. So you have to see with a perio probe 1.5 only. You want to stay in junctional epithelium all around, and if there is blood, that means there is perimucositis, and you need to put the patient on hydrogen peroxide and doxycycline toothpaste that you will create. Now today, Dr. Sharif was even adding another way for supplying the patient with doxycycline, because I tried this technique, it failed. I placed doxycycline in the water jet and it blocked the pipe. So he said if you use the coffee mixer, and then it becomes more, we can try it and see. Huh? No, it becomes smaller, right? Yes. The particles become so small, it doesn't block the water jet.
So it's a tablet?
No, you buy it in capsule, which is powder. You empty the powder, it's too big. So what we do, we apply it on the toothpaste. We divide, you have,
I know, but I want to know the formula.
the formula is 20 milligram. How you take a tablet which is 100 milligram and make it into 20, you divide it into 5 pieces. You give the patient a capsule or whatever you want for 20 milligram. You ask him to put it on the toothpaste at night, brush for 1 minute or 2 minutes or 3. Minimum is 2, maximum is 4. I like 4. So when they brush, they spit and they don't rinse. This is my protocol for toothbrush. But he's suggesting to add also water jets, so it goes deeper. So I had a problem with the water jet because it blocked all the, so I stopped giving it to the patient. Now he's saying if you use the coffee mixer, it will work. Worst scenario, if it does still block, we can try the small grinder you have for the pepper and coffee, we can try that to go back to the water jet. Seems to be water jet is a good idea because it goes between the papilla and the brush might not go. But anyway, so you have hydrogen peroxide. What's the percentage of hydrogen peroxide for daily use?
1%.
1%. 1%. That's the ideal for daily use. So you put the patient, once they are bleeding, you put the patient on that, and then you call them in 21 days. Why 21 days?
Soft
Because
tissue
it
will
needs
be
21 days for the soft tissue to heal.
And it needs 21 days for the bacteria to die. So if the bleeding is stopped in 21 days, you continue with the patient or you tell the patient to stop, it's up to you. But he's no longer an annual patient. He becomes a 6-month patient.
Since we want this doxycycline to work in the area that we need it to work, would it be also a good suggestion to add it to a gel and then place it?
How to place it?
Like you place a ginger gel, for example. If you add to that the powder doxycycline,
So you put that on a toothbrush?
you can do that on a toothbrush or place it manually in the area between the implant.
Yeah, but if the patient is already doing brushing once, twice a year as a culture, as a habit, why you want to add another habit that they might forget? Why I do things where already the patient will not forget is I try not to give them a new habit. Because, for example, since 1989, I'm doing dentistry. You know how many times I told the patient, I told you about flossing, are you flossing? And they told me no. I crossed 40,000 patients. They told me no, I'm not flossing. So I got fed up of giving the culture, if the patient is flossing, then he will continue flossing. If the patient is not, normally, if I spend half an hour giving them the important, maybe for 2-3 days they will listen, they go back to their culture, which is not flossing. So, I don't think they will add a new culture as a common to apply the. How many of you patients are not applying the ginger gel? Most of them.
Okay, but I understood that you mean by this protocol either by the water jet or the toothpaste.
Because
The brushing, this is for life?
no, 21 days. 21 days. So my point is, if the patient has a water jet, I will try to do that. If the patient doesn't have, I'm not going to waste, because they will not buy, and I will be thinking they did buy, and when they come next time, they will lie to me because they feel shy to tell me they didn't buy. So to me, toothpaste is something I can say 99% of my patients are brushing their teeth. At least once a day, at least. It's a culture, it has become a culture. So I don't have to add another culture. It's just add powder on top of your toothpaste. And I don't say buy a new toothpaste. Your toothbrush.
Twice a day, right?
No, I think once a day at night is enough. You don't need, I need that night cycle. So I tell them only before going to bed. Morning, I don't think it's really that effective because they're going to eat, they're going to rinse it off, they're going to. I don't think morning will be that much useful. And because it's a 20 milligram per day, so doing it twice a day may be overdoing it. So it's once a day at night time. And once I find it, always I find the bleeding stops. By the way, I've never had a patient who comes. Unless there was a 7 millimeter of pocket, which is too late anyway. Even with them, I found bleeding stops. So It's an amazing formula. Interproximal contact. Now the question is, we mentioned this a few times, why we switched from porcelain fused to metal to zirconia? Because we expect 4 to 7 years there will be interproximal gap, especially with patients who had orthodontic treatment when they were young. Because I know 20% of my patients will have interproximal gap, if I use zirconia, I can take the crown, send it to the lab, same day they add, they send back. If it's a porcelain fused to metal, it's going to crack, I need 1 week. So that's why we are expecting interproximal contact to be created. So if we can check with a floss every time they come, once in a year, and we find a gap, we don't close our eyes. If the patient doesn't complain, we will also not say anything. We just take the crown, send it to the lab, and put it back with the bigger size. Occlusal contact, what I have found is I have better bone when there is occlusal contact versus when it's out of occlusion. The bone quality in terms of radio opacity is better actually. So to keep all implant crowns out of occlusion, I have I'm not going to mention names, but one of the sheikhs, the 7 sheikhs, right hand, who's the mustashar, he has done implants elsewhere in Dubai, and all his implant crowns are out of occlusion, like 2-3 millimeters. So only he's eating with the front teeth. So it's very easy because the dentist doesn't want the implants to come out, it's cemented. They make it out of occlusion, so it will never fall. The cement will never dislodge because it's out of occlusion. But that's not how you use an implant. It has to be in occlusion, and it has to be in a proper occlusal level. So to me is, a patient has come, they have paid the maximum the doctor asked, not the minimum, and they ask for the maximum benefit, the maximum quality. So if we don't pay attention to the occlusal contact, basically it was a lack of service, I think, because the bone quality will be reduced, and if the patient gets any kind of a disease like Alzheimer or diabetic or whatever, that bone is very soft, and that bone, if it doesn't have a thick phenotype, it will start receding. So occlusal contact is a way to make the bone density higher. Eccentric contacts, what we don't check when we write the eccentric contact here is, what is the theme of occlusion in that area? You should write group function, canine rise, whatever it is. Why? Because when the patient comes next year, and then you don't know what was the previous year, and something is chipped off or broken or extracted, you don't know how to restore the patient. The patient, if the patient is group function, and you restore him in canine rise, he will have a severe headache, severe pain, muscle pain, he will be uncomfortable. And you check, it's canine rise, it's physiologic. The patient says, I cannot talk, I cannot eat, I'm very uncomfortable. You should have put him back in group function. He was group function. But you don't have a record because you didn't record the eccentric movements. To preserve the case, I think it's a must now for 10 years. So please don't throw the case or remove the analog and use it for another case. When they come back with the open gap after 1 or 2 or 5 years, it's not only the tightening that we want to know. We want to know the torque of the implant at the day of surgery. We want to know the ostel at the time of uncovery. And if that's not available, at least we want to know the any check at the time of uncovery. And we want to know the tightness when you install the abutment. And if it becomes loose, then next year you write then what you did. If you change the screw, whatever you did in relation to that screw, it should be written in front of this. How did you tighten it? How much did you? If there's 2 screws, why you have 2 screws?
Regulation. One.
Multi-unit. So you need to have the both numbers. Why? Because if it breaks, you need to know why it broke. And if it becomes loose, you want to know why it became loose. So that's why it's either related to occlusion. What is occlusion? Occlusion. Or it's related to the screw itself, or related to your tightening. Abutment implant seal, if you are dealing with a good conical connection, maybe it's not the big deal, but if you're dealing with internal hex, there is a very bad smell every time you open, and you want to put some kind of a seal, not to have that bad smell coming out of the mouth. And of course the hole closure, it might be very simple here, but that hole closure is your occlusion. So the patient is actually eating on it. So if you don't pack your Teflon nicely, and you just put Teflon, I've seen you roll it and you put it, don't do that. Put the Teflon without rolling, pack it, leave 3 millimeters, and put your composite on top. That's how you put the hole, and the patient can eat on it. Instead of the patient comes with your composite has gone deeper, and always there is food and they don't. And always use the color of the crown. Don't make it brighter or lighter or whatever. All right.
To point number 6, can you please explain what is the eccentric contact?
So what we do is we pay attention to the day the patient came for diagnosis. He is missing a second premolar. We check on the day of diagnosis before implant placement. What is the occlusal scheme around this area? If the patient is a canine rise on this premolar, yeah, we make sure the premolar of the implant is not touching on the eccentric movement because he's a canine rise. If he's in group function, we make sure it touches. So every year we make sure this area is group function. Now years pass because we are dealing with these patients for 20 years. I remember my first case in Dubai was 97. I still see those patients. They still come. 10 years, 20 years. The lady we saw in, how many of you were in level 4? Only Zainab, which is not listening? From Bahrain. How many years? 20 years later, or 18 years. Anyway, around 20 years later, she came back. So, and she broke some other teeth or something. If I don't know what is her occlusal scheme, I might make my crown in a different occlusal scheme, which will ruin everything. So, we should know this area is what kind of, even if it's a crossbite, we make it crossbite and we keep it first.
Place the restoration and we put our paper for biting. Which points we have to reduce? Like how we know that this is in good occlusion already?
All right. Imagine the, no, it's okay.
This one, small one.
No,
Like
it's
an
okay.
articulated
No, it's
paper?
okay. No, it's fine. Imagine, pick a tooth.
Molar, first.
First lower
Forceps.
right molar. First right lower molar. We just place the implant crown, right? We give her, give me that piece of paper. We have an articulating paper in that area. The articulating paper should not be bigger than the crown. Many of you, I see you have a big articulating paper touching 2-3 teeth. The articulating paper should be smaller than the molar. Don't use long ones, it's not helpful. So you put that articulating paper, you don't have to, I'm just showing you. You put it in the molar area and it's not touching the neighboring teeth. It's only touching the molar.
Yeah.
And this is not as thick as available. This is within limits of 25 micron, the one which is standard. You ask the patient to close. the teeth together. Close. Lightly. But close. All the teeth should touch. And when you pull this out, it should come out. Okay? And then you ask the patient, again you dry this, you dry the teeth. You have to dry the teeth, otherwise it will tear. If it's a good quality, it will tear. You put it again and ask the patient to do maximum intercuspation, and it should not come out. In this way, you know, when all the teeth are pushed against the periodontal ligament space, the implant is also being activated. If you put it slightly and ask the patient to bite gently and it's not coming out, be sure when the patient is biting maximum, this is the only one which is touching. So then it's actually not good, yeah. So you want, thank you, you want the implant to be activated in maximum intercuspation, not in centric occlusion, in maximum intercuspation, which is more than just lightly close your teeth.
Example that was before the doctor's question. If we don't have any way to get an occlusal, an eccentric contact because the patient has from 4 until the 8 gone. Premolar, first premolar on one side until the back teeth, they are not there.
They're not there.
So
the canine is there?
The canine is there.
Okay, so as soon as the patient goes to that side, say right lateral, you want to have a space between all the teeth and the opposite teeth. When it's in maximum intercuspation, straight, then you want them to touch. As soon as the patient goes to one side, none of them will touch. This is canine rise physiologic occlusion. This is protective occlusion. This is, they call it green occlusion. This is what you want to create if the patient doesn't have any. This is not the problem. The problem is the patient comes with group function and a tooth between them is missing.
Yeah, I understand.
To be canine rise always, no. For those patients, or the patient comes with a canine missing. You don't know he was canine rise or he was group function. Because when the canine is missing, he automatically
Group function.
is become group function. So you check the other side. If you find the other side was canine rise, hopefully you put canine rise here. And if the patient is happy, you stick to it. And if the patient says, no, I cannot eat, then you make it group function, including the canine.
So in the case that I gave, if you have the premolar, is it logical to assume that they are going to have the same centric contact as the other side?
No, not 100%. I have many patients who have different, because the way they lost the opposite teeth is different, the timing is different. Not a necessity.
Not necessary.
It's just the starting point.
Okay.
Do I check the lateral movement?
Yes. The only way to find eccentric is lateral movement.
Oh, with the articulating paper.
No need with your eyes.
No, if the patient eccentric, he said, okay, doctor, there is no touching, but when I shift right or left, there is something hitting.
That's it.
I
That's the
see.
one you put articulating, and if you want canine rise, that spot should be eliminated.
Oh,
And if you want group function, you want to make sure all the 3 teeth, the premolars and the mesiopalatal cusp of the molar,
your palatal.
yeah, mesiobuccal, sorry, cusp of the molar should touch. The other cusp of the molar should not touch.
Should not touch.
That's group function. It's not group function means everything touch at all times till the 3rd molar. No.
Only the
Only one
buccal cusp of the
molar,
lower.
both premolars.
Ah,
And if the canine is there, why not?
okay.
If the canine is not there, then not there.
Oh,
Same thing, if the patient, the other side is canine rise, leave it. If the patient is group function, leave it. Don't change the patient's, because it took 50 years for the patient to be habitual in that position, right? Why would you come and change it? Don't change it. Alright. So this statistics I'm giving you is based on around 4,800 patients. Growth by learning. So one thing is, what we know is anterior mandible, you will have 9% of your cases will be missing anterior mandible. Then when we go to the posterior maxilla, without sinus lift, is 24%. So a lot of people are missing the premolar. Then when you go to the posterior mandible, it becomes 32%, which is the highest. And then you go to the anterior maxilla, which is around 30%, and the sinus becomes only 5.5%. So why is this important? Is it's telling you the population that are going to come to you are like this. So generally, you have to be comfortable to the most of your patient with posterior mandibular equipment, instruments, something that you don't injure the nerve, anything related to the posterior mandible. In terms of sinus, maybe you don't need to invest too much because it's going to be around 5 to 6% your patient population. Why these statistics are important? If you want to invest in a technology, okay, and you want to invest properly, you should know what kind of patients you'll be seeing more often. When I say invest, I don't mean money only. If you want to take a course for aesthetics, all right, anterior maxillary aesthetics, that course will contain 30% of your patient, not all your patient. If you're taking a course on anterior mandible, for example, overdenture or something, many people think overdenture should be taught. It's only dealing with 9% of population who need 2 implants in the front end. Not many people today will want that tuck overdenture because anterior mandible is the only place you can place implants. So this is just for you to know where you stand in terms of world population. So class 1, 2 without sinus lift, 3 posterior mandible, 4 anterior maxilla, and 5 is the sinus elevation.
Doctor, these numbers related to the severity or difficulty or what?
Also,
And why is the lower?
one is the simplest. Minimum equipment, minimum time, minimum ancillary procedures, minimum bone grafting, minimum soft tissue augmentation. 2 will have a little bit of bone grafting because there's a depression on the premolar, little bit. Level 3, maybe splitting, putting some grafting, soft tissue grafting, the vestibule is shallow, nerve is there, and so forth. Level 4, everybody knows, is the worst nightmare if you are not good with soft tissue and bone grafting. Level 5, you have to be very slow, you have to have many equipment to be able to raise the sinus in a way that you don't perforate, you fill it with bone graft that doesn't resorb quickly, and so, yes, it is also the complexity will increase by the number. So this is the least complex, second, third, fourth maximum.
But the lingual artery in class 1 is not a big deal.
It's not. Why? Because once you know it, you stay away from it. Before they didn't know, nowadays there's nobody who kills a patient with that because you can easily see that line and it's in the midline. So you stay away from it. The lady that you treated with soft tissue graft, Tina, she was lucky because there was an artery and you remember that doctor placed the implant in the wrong angle, one for 2 teeth. If he would have put it straight, the patient would have died because he put it in the midline,
The middle of
and he, by luck, he made a mistake and put it in wrong angle without having CBCT,
Okay.
And that saved the patient. Little more down, little more straight, he would have touched the artery. So she's lucky. In terms of time, also its complexity, anterior mandible, because it's visible, you can see it, it's not against gravity, you don't have to, so because it's down and you can always hold it, and you don't have to have a stopper and all those complicated things, as deep as you want you can go, so it's normally an average of 19 minutes is enough, plus or minus 10 minutes to place an implant. Inherently, you know what inherently means? Within it, it doesn't need many procedures. It's generally one implant just includes. As you go, also inherently, bone graft will add, soft tissue graft will add, this will add, sinus, you know. So the second one is around 30 minutes. It's the premolar because you need to add a little bit on the buccal concavity, some 2 millimeter, 1 millimeter of bone. With easy graft crystal, it's very easy because you just go, fill the depression and close. If you want to put membrane and bone, it takes longer, but still it's within 30 to 40 minutes maximum. Once you go to the posterior mandible, because of the nerve, because of the splitting, because of the soft tissue, because of the vestibule, all that will add time, and the stopper, you cannot just go, you don't want to touch the nerve, it adds time to your procedure. Once you go to anterior maxilla, your incision is delicate, your burr is fresh, your angulation of your, sorry?
This is class 5, right?
No, this is 4, anterior maxilla. For the anterior maxilla, you have to have other issues. Generally, how are you going to suture it back? Aesthetics and all that. How are you going to make sure the papilla is maintained? So that adds another few minutes. With the sinus, you have to be very slow because if you tear it, you cannot go back. So it takes around 50 to 60 minutes. When it comes to the cost, of course, anterior mandible is the least cost for you and the lab and everybody. Once you go to the posterior maxilla, the cost is slightly more than posterior mandible, even though posterior mandible takes longer. The reason is you might not find always depression in the posterior mandible to put little bone graft, but you mostly can find little depression in the posterior premolar area to put little bone to build it up. So that adds cost, but not too much. It's little bit. Half a gram is enough. So the cost goes up in posterior maxilla. Mandible, the cost is lower because normally you can manage with existing bone. Or you can flip the gum. You don't need to buy anything. You can use the existing. So the cost is still higher than anterior mandible, but it's lower than posterior maxilla. Once you go to the anterior maxilla, the cost suddenly goes up. Because you have to have bone graft, you have to have tissue graft, you have to have membrane, you have to have tags, you have to have screws, you have to have so many things to be able to do a good anterior.
Maybe immediate loading,
Maybe immediate loading, temporization, anterior, maxilla. And sinus, you need a lot of equipment to purchase those. Each one is like 5,000 dirham, each one. So it adds up to your overhead a lot for the instruments, not material. You have to buy those instruments.
Since the posterior mandible is lower in cost, why is it than the yellow? Why is it put in third place? No second.
No, this is already more difficult. It is already in the complexity chart.
Okay, so
Because there's other elements. There's a nerve, there's a... Cost is not the only complexity. There are other things that make it complex. Cost is just for you to know, even though this is more complex, it doesn't mean it's more expensive. Now we come to the average procedures. Again, it is back on the cost and the procedure are related. The more the procedure, the more the cost. So if the cost is cheaper here, that means less procedures are in the posterior mandible. So the minimum procedures are done in the anterior mandible. More procedures than anterior mandible is in the posterior maxilla. Then less procedures in the posterior mandible. More procedures than everything here in the anterior maxilla. And of course, the maximum possible procedures you can imagine. Buccal bone graft, internal sinus lift, soft tissue flipping, bone grafting, tearing the membrane, adding this and that. The maximum possible procedures and the list of procedures can happen here. Nothing can happen here which is not here. If you want membrane, you can have it here. I mean, you say, I need membrane for the anterior maxilla. You might have membrane needed. I might have bone graft needed. You will have one. I might have a blood graft needed. You might have a blood graft here. I might have it. You will have it here. So there is nothing left in implant dentistry procedure that you might not have it here. It will need it.
Connective tissue graft. You don't need it.
You might need it. Many times you might need it. Yeah, anything you think of, you might need it here. Alright, now this one is the Hounsfield unit, which is not the same escalating. The hardest is the anterior mandible. Then, and posterior maxilla is much softer. Then the posterior mandible is harder. Then anterior maxilla is still harder than posterior maxilla. Then the softest is the sinus. So this is not nicely like this. This is different now because it's related to bone density. Yeah. So the bone density is different. Bone density is not related to the complexity. Bone density is related to Hounsfield units. Just because anterior mandible is the hardest, okay, it doesn't mean it's the least complex or it's the most complex. It's just the density we're talking about, yeah? It's interesting to know that the anterior maxilla is harder than posterior maximal, even in the premolar area. Once you cross the canine, because once you start from the premolar, it becomes posterior maxilla, right? Once you cross the canine, it suddenly becomes softer. Yeah? Okay. Okay, so now we are dealing with how we're going to learn implant dentistry by knowing all the 5 steps and why it's good to recognize all the 5 steps, because anything goes wrong, you have to know when did it start. So you can solve a surgery problem, okay, during the surgery itself. If, for example, you see a broken crown, right? A broken crown is a restoration problem. So you know the solution for it is not surgical. Because many people come to the clinic saying, I have this problem. If you cannot recognize where is the classification of this problem, you might, for example, a patient comes says, I have a problem with my implant. The reception will immediately refer it to the surgeon because it's an implant problem. Yeah? But if, and only if, the patient says, I have a broken crown, maybe the reception will not look it with the surgeon. So, once you know which stage is the problem, Also, so to know which stage are you is very important. I will come back to this detail later. Level 1, 2, 3, 4, 5 is the complexity. D1, D2 is the diagnosis. When we come to the next, you'll understand what is this classification. Now, during diagnosis, the topic is when and where. So for diagnosis, how does this structure of the shape of the implant help you during diagnosis? Yes.
And the quality of the bone, I can't.
Exactly. Fantastic. So,
The
yes.
depth of the implant that should be placed in, is it eye bone equivalent to the bone level or 2-3 millimeter?
Yes. So the soft tissue thickness will also determine where you want the implant to be placed. The patient smoker will determine maybe you should not use very aggressive threading, because after 5 years, if he's going to have bone loss and depression is there, Dr. Sharif's favorite procedure is to shave the implant with the diamond burr and then put a connective tissue graft, correct? So if you are already dealing with the shisha addict, yeah, maybe you will not go with such aggressive neck. You go with a simpler neck. So even after 5 years, if there is resorption, still he can do his soft tissue grafting without getting a diamond and cutting the implant, right? So the diagnosis affects your implant selection.
Your diagnosis affects the implant selection, not.
Hmm? Say what is in your head.
No, I
maybe.
mean, the implant selection is start from diagnosis. That's
Yes,
what I mean.
yes. Not you look on the size and the height, and then you order the implant. Also, how is this patient fitting this? For example, you deal with a tissue level implant. If you want to,
The failure rate or prognosis
yes,
depends on this.
yeah, also
Oh,
the highest failure rate is the most complex, and it
science.
reduces. The second worst is the anterior maxilla. The third worst is the posterior mandible. The fourth worst is the posterior maxilla without sinus lift, and the least failure is the
Lower anterior.
anterior mandible. So it is also related to the failure rate, this complexity. That's why when you saw the cost, who said why? The cost doesn't make your failure rate, but your failure rate is that escalating complexity. Yeah, the cost and the Hounsfield unit is not related to your failure.
Not related.
Statistically, they are not relevant. You can have soft bone, yeah. No, you can have low Hounsfield unit, and you do expansion, and you make it hard.
Oh,
Alright, surgery. When you're doing the surgery, how does implant selection make a difference? The same concept we mentioned. If you're going to place the implant below the bone, if you have a 3 millimeter of cuff height, soft tissue height. If you have less than 3 millimeter, when you think is a good time to do the soft tissue graft? Because what we are finding now, if you have a thick phenotype, there will be bone formation under your thick phenotype, which is great news. So when you have a thin phenotype, you have resorption. If you have an average phenotype, it's probably stable. If you create a thicker phenotype, I'm sorry, I didn't apologize. If you create a thicker phenotype, there could be bone formation under your connective tissue. Formation, which was not there. You didn't do grafting. You did not do bone grafting. You only thickened the soft tissue, the connective tissue, you made it thicker. You come back after a few years, you found there is new bone formed under your connective tissue. This is fantastic knowledge, fantastic information. So when you have 2 millimeter of soft tissue on your implant, maybe looking only at the bone is not the best thing. Maybe also looking at how I can make this at least 3 millimeter before I look at the bone. Do you
Yes.
agree with me?
Yes, not only the vertical thickness, doctor, even the buccal
yes.
cortical plate, it will be resolved by time. So if you have
No, not only occlusal, everywhere.
yes, everywhere.
So looking at the soft tissue to give you extra bone is something we didn't know before when we studied implant dentistry. Now, the last 5 years we know. Because thick phenotype can create bone which is not remodeled by osteoclast. Alright. Now this is a hot topic. This is a very hot topic.
Okay.
To bury and close or to keep the gingiva open and
Merge and submerge.
merge, submerge,
Depends.
it's called 1 and 2.
One stage.
1 stage, 2 stage. Okay, now I have a few, let me see if I have another photo. No. Alright, now, this is very important. This is based on the latest knowledge that is coming out. If the patient is having full mouth and you want to do, say, multi-unit abutments for this patient to give him a full restoration, and the patient cannot afford immediate loading. So you have to bury the implant because he's going to receive a removable denture. So you are forced to do cover screw and finish it off because of the other things that the patient doesn't want. Now imagine, or for example, it's a single implant. You place the implant, there is no primary stability. You are forced to bury the implant, close on top, because you're worried the implant will move based on your healing abutment with the tongue or with the food or with whatever. So sometimes you are forced to do what you don't want to do. Now, this is the trick that is not there in this photograph. If you have an extraction socket, this is the topic of today. Neither this, neither that is ideal. The ideal is the dimension of your soft tissue should be kept as it is. This is not the solution.
Reservation.
Yeah. Yeah. Now, either custom make abutment. Today, who wanted to do custom made? You are the one? I told him, do you have a temporary abutment? No. Do you have, what do you have? Nothing. So how are you going to make custom make abutment? I have a putty from the consensus. I put then how is going to stay? How you going? You understand?
Yes.
So custom make abutment, you have to be prepared for a custom made abutment before the patient comes. Or you make multiple, small, medium, large, and then you shave it based on the patient, and then you reline it with flowable. At least you have the base. Otherwise you spend 1 hour only on this abutment. The closest what we have to custom make abutment is the iPhysio. It's not custom made, but it's the closest. Why? Because that 1.5 millimeter of connective tissue support without pushing is embedded in it. Because if you make a custom make abutment and you don't give this 1.5 millimeter concavity, your custom made abutment is worse than your healing or even cover screws. Yeah? You will have a collapse, but you will not have bone remodeling. So it's very important. Don't just say custom make abutment and you don't know the principles of a of a good healing, and the remodeling should be not with resort. See, what is remodeling? If you have oven bone, you know oven bone? No? Oven. If you have oven bone, this oven bone should change to what bone? Lamina. Who said? Yeah, lamina bone, right? Is this considered remodeling or not? Yes? Correct? Okay. Now you push the connective tissue in the wrong way. Okay? So the connective tissue has to find another place and it will resorb the bone till the connective tissue will find a comfortable place. And you lost 1 or 2 millimeter of bone. Is this also remodeling? Yes. Thank you. So what's the difference between woven bone changing to lamina bone and to losing 1 millimeter of bone vertically? What is the difference? Both are
Reposition.
no, both are the same term. We are using one term.
Negative and positive.
Okay, favorable, unfavorable. What else?
Negative and
So
positive.
negative, positive.
Desirable, undesirable.
Desirable, undesirable.
Yeah, but in one you have changing of the bone structure,
Density.
and the other
Density
you are
is
having
changed.
disappearance of the bone completely.
Yeah,
Because it's bone
yeah,
deposition.
yeah.
So how is it remodeled? It's not deposition.
No, but
It's
it
a
is,
reposition.
in the textbook, it's still considered remodeling.
Yeah.
Once the woven bone becomes lamina bone,
That is changing structure.
it's called remodeling.
Yes. And the other when you're losing.
Also, it's called remodeling. The bone remodels to a new position.
Okay.
No, my point is, you mentioned few of the things to differentiate them, but I'm looking for more useful words that I can benefit in my clinic.
Additive, subtract.
Okay. What else?
It becomes more load bearing,
Okay, fine. What else?
more organized, more like
When you mean
bone pattern.
woven to lamina?
yeah, laminar,
Okay.
yeah, the
And
bone-
what about the other guy? What about the second one?
Let's say guided remodeling. يعني
Guided. Which one is guided?
You decide how the remodeling will happen. As a
Slowly
surgeon.
you are going there. See, if you pay attention to the connective tissue, the remodeling will be desired remodeling.
ally.
Huh?
He will be your ally. He will work with you.
I did it.
Yes,
By knowledge, I did this.
yes. It will be you put the principles
How-
for the remodeling
how
to
to do it.
occur, versus you allow the nature to take its own path. It could be positive, it could be negative. For example, when I say adding connective tissue inside the soft tissue, you take a palatal graft, remove the epithelium, and thicken the connective tissue. Another remodeling will happen, correct? Yes or no?
Yes.
Yes. That remodeling will make new bone for you. This is remodeling also. So if you can control remodeling, that's what we are
Guided remodeling.
guided remodeling. Yeah?
This is the term.
Yeah, so you are the one who's telling the cells what to do for you. If you're awake and you know what you're doing. So,
Or it's a forced remodeling.
forced remodeling.
If you do
That's
something wrong, if you put the abutment like too much deep to the bone, so you're forced the bone to go away.
Yes.
This is forced.
okay, exactly. I agree. So my point is, even this and this is telling the remodeling what to do. You understand? So every element you put, even though it's very insignificant, because the factory gives you this and this, and you say, okay, today I put this. There was no primary stability, I put this. There was primary stability, I put that. But actually, everything you do, you are telling the remodeling what will happen. But if you don't know, it's unknowing remodeling. It's like you don't know what's going to happen because you don't have enough knowledge about the negative effect of this, the negative effect of this. or the positive effect of this and the positive effect. So the more you know, how does this help you in remodeling? How does this help you in remodeling? The more controlled remodeling you can do. And the less you know, the more nature will do his own thing. So every detail of everything you do will affect your remodeling. That's what I want to clarify. Yes.
I mean, you are not saying use this or that, but whenever you use this or decide to use this or that, you have to know why you are using this.
Because it's going to remodel.
Yes.
The
Because
body will react to your action by remodeling. The body doesn't know how else to react. There is one word for us, remodeling. The body will remodel according to your action. So if you put a cover screw, what is the remodeling? Collapse of the soft tissue. Finished. You will collapse that soft tissue and you will never get that shape again in your life. Ever. Never you will get it. Finished. You collapsed it. Because of the memory for that shape is gone to this shape. Even if you make an incision and you open the flap, you put the crown, the soft tissue will go back to the last memory, not to that big white memory. So the closest way to keep it is the iPhysio ready-made. But if you want to make a custom made and you're ready with temporary abutment, composite, why not? Make it custom made. Great, your remodeling will be in your favor because then the memory of the position of the gum will remain open, right? And it will stay like that till you come at the day of uncovery and you take your impression and you put this back, you get your final crown and this will remain. So you decide on the remodeling.
Doctor, is there any statistical significance between cover screw and healing related to osseointegration or?
No, definitely osteointegration because immediate loading has shown similar success than two-stage loading. Not better actually. It's just almost same. So then we realized that this was not the cause of failure. There were other elements that made us think this is better than this in the olden days. Because immediate loading worked.
Okay.
So if immediate loading can work,
So
that
the
means
healing,
it's already, these are the same.
Oh.
But with the elements of immediate loading, this should be 35 plus.
Oh.
It should be this. It should be not more than 100 micron movement. No bone grafting,
Oh.
and all that.
Oh, okay.
Yeah. Yeah.
How an extraction socket that you will have for
No. I'm not saying don't put bone graft. I'm saying an extraction socket. As soon as you put this guy in, even this guy, the memory that is keeping the gums open wide will follow within 21 days. They forget. They follow, they will remodel to the new position, and that becomes the memory. So later, when you do anything, they will go back to this position. You understand what
Yeah,
I'm
I
saying?
understand, but if we put bone graft in extraction subject with everyone, yeah, you can't do you can't put iPhysio, I think, or the
You should.
Why you say
no immediate loading.
loading?
Immediate loading.
I
Yeah.
think for the
Actually, I'm not the one. Actually, the person who taught me not to do immediate loading with bone grafting, Paulo Maulo, the last time I met him, he said, "Duke, I'm doing now." I said, "What about failure rate?" He says, "Doesn't
No, but-
matter." So he is risking more than 20 years ago.
Yes, but
also there is
He is in a position he can take higher risks.
You need money.
He must be very
Because he convinced me 20 years ago that the cells that are dealing with bone replacement, when you do a graft, they will not osseointegrate. They are busy with this bone graft. So if you have immediate loading, means you have another pressure, those cells will not have enough oxygen or the amount of oxygen and other elements they need to do the osseointegration, at the same time deal with this second headache, which is the bone graft. Because when you have a bone graft, the autoimmune response to deal with this foreign body is different than to deal with titanium foreign body. It's a two different ways to deal with it. When the cells come and acknowledge a bone graft, they have to send different receptors to deal with this foreign body, right? When they touch titanium, it's a different cycle. So when you add another one, okay, and you put load on top of it, which is moving, this guy is not welcome. Because moving and bone graft is not something they can handle.
But you take it out of occlusion.
Even there is pressure. So when they have a bone graft, very easy for them to encapsulate the bone graft to keep it out. They don't want this foreign body with movement. So that's why he was saying don't mix.
And now what changed?
He said do it. I have done and it works and do it. I don't think he's having statistics to publish anymore. He reached a level where
Because Thomas says that you can put you should put actually.
immediate loading. He doesn't encourage bone graft.
He says bone graft is okay. And he encourages actually immediate loading in anteriors.
Immediate loading, everybody encourages, but nobody encourages better success of bone graft and loading. No one.
Jumping distance, he encourages.
Okay.
You
All right.
didn't try before
I think-
immediate loading?
Sorry?
You didn't try before immediate loading and see the result?
No, we do a lot of immediate loading in my practice.
What's the result?
Good. But we follow the laws of immediate loading. We don't do immediate loading with risk. We do immediate loading when we should do immediate loading. And it works. Yeah, one unit immediate loading is better. Yeah. Yeah. Yeah.
Okay. I mean, when you can do immediate loading if your implant is surrounded by natural bone, and you put the bone graft as just to have a thickness or to fix the shape. That's it. But it's not related to your implant surface. But when your bone graft is touch your implant surface, or you have a big gap and you put bone graft there, I don't advise for
That's what
loading.
he was saying, don't do it. It was a must know.
No, I mean the idea, how to do or when to do, when not
It's a
to
good
do.
idea to have this curtain.
Yes.
If you have your wall of your implant surrounded by artificial bone, and this little movement might create epithelial encapsulation, don't do it.
Yes.
That's what you're saying.
Yes.
But most of immediate extraction and the immediate loading in the anterior, we are filling the jumping gap.
Yeah, but he's
Yes.
saying not the entire, not full wall, only the neck, 2-3 millimeters, but not the whole surface is filled with artificial bone.
Exactly.
That's what I think is the.
And we are covering this bone graft, doctor. We are making seal to it, or
The temporary crown itself is sealing the hole. There is a few articles on extraction socket membrane is worse than extraction socket no membrane.
with membrane is worse.
Yes, with membrane you have higher failure rate than without membrane. Whether you put bone graft or not, it's a different story. People say fill it up. Some people say don't fill it up. I'm in favor of fill it up. But the membrane on extraction socket has higher failure rate than no membrane. The bone graft is another topic.
But also, doctor, I'm sorry, but also it depends to the which membrane.
Yeah, but extraction socket and membrane, it's
Now,
somehow...
this, for example, last membrane, what you show us, this, what's the name?
Magnesium?
No, no, no.
Amniotic.
Yes. How it is with extraction socket? Because it doesn't stop the blood supply. It will
No,
be.
but the point is, are you putting a tooth on top or just covering the extraction socket?
No, just covering the extraction socket.
Just covering is okay, I think. We're talking about stuck between the crown
Ah, okay.
and the bone.
No,
That
but
membrane is-
collagen membrane or.
No, if you seal it, no problem. We use non-resorbable and it's working very better than no membrane. If you are not putting
You mean
I'm
on-
saying a membrane between the temporary crown
Okay.
and the bone is worse than nothing.
I understand.
The crown itself can protect your bone.
I understand.
That one is what Turnau, he said also, this Hussam Hamdi was saying, even Turnau was saying, if you're putting a temporary crown, don't put a membrane in the middle. It doesn't help. Actually, it's worse. Because it acts as another layer of foreign body between this foreign body and this foreign body. Alright. Now let's walk into the world of digital. Now, you place a digital impression post on this implant and you scan. Alright, you with me? The scan is telling the relationship between this, because the connection is tight, between this implant and the neighboring structures, gum, teeth, whatever, right? You with me? Till now it's clear, right? You take that, put it here, tighten it, scan the relationship between this and the neighboring teeth, because it's in one picture, right? It's recorded, right?
Right.
Till now, it's very accurate. What makes it inaccurate is because the lab wants to work, right? They want to work. Why would they scan if they don't want to work? It's not keeping the frame in the bedroom, right? To work, normally they print a model. Printing has a lot of errors. That printing is actually the reason why a bridge is not passive, not the scan. The scan is little bit, say 0.1%. But the model that they have to work on has like 2% error. When you have multiple teeth, 2% by 6, it's a lot of error. So, if the lab can do all the work virtually without printing, the fit is better. Everything is done virtually, not on the model. It's more accurate than your manual impression. Because your manual impression also needs a cast. Your cast is expanding. The printing is shrinking. The impression material is shrinking. So every time you get out of the digital world and you use a material, either it will shrink or expand. That is what you are against, you're fighting with. So if the lab can reach a standard, everything is done virtually from A to Z without a model, and they send you the crown without a model. A crown doesn't matter, I'm talking about a bridge. And they did not fit it on the model, they actually kept it on the virtual world. It's more accurate. But unfortunately, they need to polish, they need to hold it, they need to see how does it, all that, still the human Mind is used to holding something and making it look nice, right? To hold it, you need a model. This is what we are still struggling.
But
One, yeah.
eventually, you will have to take it out from the software and make it into a real physical thing, either by printing.
No, but that physical thing, okay?
Will have less errors than
Then,
if you use
yeah.
other.
Now, that's what I was trying to compare. Many of you say digital. Manual has another error. Digital, because of the printing of the model, has another error. Open tray, of course, is more accurate than closed tray. And there are companies, say Zimmer, they make the open and closed tray in one type of impression post. And you have the closed tray. When do we use the closed tray? When we want to choose the multi-unit. You don't know how to choose the multi-unit. You make a closed tray, you send it to the lab. The lab will find the best angle and the best height, and they will tell you, for this, you buy this, for this. So they'll give you 12 numbers with 12 sizes, and then you put the multi-unit, you tighten it, you take another impression at the multi-unit level. So to find the ideal angle for a multi-unit in the mouth, it will take time. And the height. It's easier to take twice the impression, once with closed tray and once with multi-unit level, not implant level. Alright, so everybody's talking about the 1.5 millimeter. So it's very important now to draw for the lab till they get the picture that this area should be unglazed and the rest is glazed. Now, all the topic that we are talking is about the cuff height. What is cuff height? Cuff height is from this margin of the abutment till the implant head. Now, obviously, this is the minimum, which is 0.5. They have 1.5, 2.5, 3.5, and maybe even 4.5. Yeah, 4.5 is the last. So, from here till the margin of your abutment is in your hand. How do you choose the cuff height? You want to keep the margin of the abutment 0.5 millimeter above the bone. So titanium will touch the bone if the implant is 2 or 3 millimeter in the bone, and the zirconia will touch the connective tissue. I'm not worried about the epithelium. I'm worried about the connective tissue. Connective tissue, not tissue. This is also tissue, but this is junctional epithelium, which I don't mind. This is what I mind. So you choose the cuff height till you bring the abutment to the 0.5 millimeter above the bone. You give that number to the lab. Then you expect the lab to build the first 1.5 millimeter straight, unglazed, because it's going to touch the connective tissue. Then everything works. This is what I'm trying to go through with your mind. This is the part. The cuff height is related to the titanium touching bone, and then everything else is related to the zirconia touching. This is what we want to create. Unfortunately, this is new for the lab, for you, for me, for everybody. This was not clear before.
Here the gum attachment, the gum height.
No, gum is a big word. What exactly are you talking about? Gingival height, okay?
Gingival height should also be considered.
That's what. If That's what we keep saying. If you have 2 millimeters, try to make it 3 millimeters from the beginning at the time of diagnosis. So once you have 3 millimeter of gingiva, you leave 1.5 millimeter touching the bone for connective tissue, and the other 1.5 for junctional epithelium. So everything else will follow. If you have 4 millimeter, which is very rare, leave 1.5 and the rest for the junctional epithelium. The problem is when you have 2 at the day of diagnosis and you're focusing on the size of the implant, the bone. Nobody's looking at the gum. I'm not only talking about buccally, horizontally, I'm also talking buccally. When you don't have this 3 millimeter everywhere, create it. At least go palatal, lingual, make an incision, roll technique, something. Try to create a 3 millimeter phenotype. So when the time comes for recovery, you have 1.5. Then he doesn't have to tell me, it depends on the, you already make your depends on the. At the time of diagnosis, you already calculated depends on the. Where is the bone? No, where is the bone? Above that 0.5 millimeter, calculate, that becomes your cuff height. So the bone will touch titanium. Yes.
So I will measure it by periodontal probe, intraoral.
Yes, you can, or you can put the implant carrier and you can measure. Take an X-ray and measure. Yeah?
Subtract the implant bone from
Yeah.
the formation.
Or just in the X-ray, when you put the implant carrier, you can see the bone level matching where. Just measure that. You know the one you put the implant?
Yes.
It fits the implant, right? You put that in the implant, take a periapical X-ray. There are lines, right? You can see where is the bone level.
Yes.
That plus 0.5 millimeter is your cuff height.
And subtract.
Solved? That's it. Not subtract. That's it. That's the cuff height.
This is the height.
Then once you put that in the mouth, the platform of the crown is 0.5 millimeter above the bone. From there, the zirconia will start. According to theory, if you keep all these elements, the bone should stay there for many years. Now, and increase. If you make the thicker soft tissue, the chance of zero bone loss theory actually is positive, not even zero. It's plus bone theory. Not bone loss, plus bone. You understand?
Additive, subtractive.
Additive. You keep raising your hand, but I don't.
Yes, no. My question is, what the relation or best relation between the free gingiva and the margin of the crown of the implant?
Wait, which margin? There are 2 margins. Which margin?
Of the crown.
This is, you talk about this? Is this your margin?
Yes, zircon crown.
Yeah, is this the margin you mean?
Yes.
Okay.
And
The free gingival graft, the free gingiva,
not finished, my question not finished. And how the cuff height may affect this relation between.
see,
And also, I know before
yeah, I'm listening.
the margin, the best position of the margin of the crown, better healthy to be under the free gingiva 1 millimeter or 0.5 millimeter.
All right, I'm trying to find.
I speak about the other side of the implant, not from the platform.
Okay, let's try to. This is maybe a good picture. Now, if pick who you are looking, come here. Now, if this was done by Dr. Thomas, this abutment was selected by who? Dr. Thomas. Where is the bone in this case? Please tell us.
Dr. Thomas?
Dr. Thomas picked this abutment.
Okay.
So where is the bone in this case?
Over here.
Go and sit down. Go and sit down. Just go. Yes, it will be 0.5 millimeter below the margin of the abutment. So now if the bone was here, this area will touch what? Bone. It will not be disturbed. It's coming packed, ready, check, finish. And the zirconia will, thank you. The zirconia will start from here straight 1.5 and then emerges profile till it gets out. I'm answering you. So how does this affect this is, if you follow all this, because the bone is touching titanium and the connective tissue is touching unglazed zirconia and the junctional epithelium is touching glazed zirconia, it is stable enough that the remodeling is not subtractive. It is maybe additive, or the same remodeling is just to maintain. Is that answering your question? When you extract, when the tooth is there, it's called alveolus, so alveolar bone. When you extract the tooth, what is that bone? No, when you extract it, that bone is residual bone. So all of our conversation should be in residual bone, not alveolar bone. Implants is not an alveolar bone. There is no tooth to have alveolus, to have alveolar bone, to have cementum, to have periodontal ligament. We should use the right terminology. What was missing in that wordings was residual bone, which is replacing the extraction socket from the alveolar bone to residual bone. At the base of that, there is basal bone, right? So we should not mix alveolar bone with residual bone. Residual bone has a different Hounsfield unit and different the way you take your right. So many things are different because it filled the gap. So it's residual bone. It's not alveolar bone anymore. Thank you very much and see you in the next lecture. Thank you.